Bismillahirrahmanirrahim. If people are doubting how far can you go far, you go so far that you can't hear them anymore. My name is Dr. Amber Arshad and today my topic of presentation is Rickettsial zoonosis. Today in my presentation, I will discuss introduction, epidemiological factors of the disease, chain of transmission, important clinical manifestations, level of preventions, and recent advances. By the end of the presentation, students will be able to describe the epidemiological aspects of rickettsial zoonosis, preventive aspects, national, global updates, and recent advances. Rickettsial disease is caused by rickettsial organisms. It's a communicable disease. It's a bacterial disease. The arthropod vectors are involved in the transmission of the disease to the humans, except Q fever. Increasingly, it is realized that rickettsial diseases are underdiagnosed and that they contribute substantially to the acute febrile burden and preventive illness in many populations. Problem statement. This emerging vector-borne zoonotic disease, there in recent years from 1940 to 2018, almost 131 new emerging vector-borne disease has been identified. Ticks are the important vectors of the disease, and they contribute to 37% of the transmission of the disease. The highest number of vector-borne diseases emerged in North America, that is 27%, followed by Europe, 21%, in Asia, 20%, by the year 2020. Risk factors include land use, with first evoke the factors of 26%, followed by international trade, commerce, and while climate and weather related factors accounted for only 10%. So the geographical distribution of the rickettsial diseases, the areas that are mostly involved include North and South America, some regions of Africa, tropical areas, Asia, and also it is present in some areas of Australia. From the year 1920 to 2016, the countries that were most affected by these rickettsial diseases were this is the geographical distribution showing the involvement of Europe, Africa, Asia, including Japan, China, and the recent and these are the causes, likely causes of the emergence, which include the weather, the international travels, and the other causes as mentioned, as human demographics and behaviors are also important key factors for its emergence. This is the distribution in Asia that mostly involves China, Cambodia, Korea, Japan, Philippines, Taiwan, and India. In Pakistan, several studies have been conducted in the recent years, which showed that some areas of Punjab and Khyber Pakhtunkhwa have been involved, and their species have been identified through several studies that will be discussed later. Rickettsia are classified into three main groups: the typhus group, the spotted fever groups, and the scrub typhus groups. These are the diseases, the possible vectors, and the possible mammalian host. The basic classification is the typhus group, and the rocky and the spotted fever group, and the other groups, typhus and Q fevers. That will be discussed later individually in the coming slides. The epidemiological triad includes agent, host, and the environment. Rickettsia is the main agent, that is the obligate intracellular parasite. And it is pleomorphic and are short rods or cocci, and they are stained with Giemsa staining, and rickettsial growth is enhanced in the presence of sulfonamides. Therefore, sulfonamides are not indicated as the treatment for these rickettsial diseases. The main vectors and reservoirs for different types of rickettsial diseases, I will explain it in detail. The disease, the Rocky Mountain spotted fever, the organism is Rickettsial rickettsii, and the vector is tick, and the reservoir is either tick or wild rodents. In scrub typhus, the organism is gamushi. It is due to larval mite, and the reservoirs are mites or wild rodents. The epidemic typhus is Rickettsial provozaki. The vector is louse, and the reservoir is human, squirrel fleas, and flying squirrels. Marine typhus is due to flea, and the reservoir is wild rodent. And Q fever has no vector because it is aerosol based transmission, aerosol transmission disease, or I can say it because of aerosol transmission. And the mammalian hosts in typhus group are humans and rodents. Similarly, in spotted fevers are rodents, dogs, and mice. And in Q fevers, the cattle, sheep, goats, and in trench fever, the humans are the mammalian host. What host factors affect the rickettsia? All ages are susceptible to this infection. Both genders are equally susceptible, and travelers are mostly affected. Those travelers who are traveling to the endemic areas of Europe and Asia and other endemic areas. And the most diagnosed rickettsial diseases in travelers are usually the spotted fevers are in the typhus groups. Seasonal variability is shown, and transmission is usually increased in monsoon and post-monsoon period that starts after July and ends before February. Overcrowding is important because whenever rickettsial disease occurs, the cases are reported in clusters. Sanitation is important, and in unhygienic conditions, contact with infected peridomestic rodents and their mites, especially during natural die-offs or exterminations of the infected rodents, cause the mites to seek out new hosts, including humans. The main modes of transmission are through bites of infected fleas, mites, ticks, or louse, and through the aerosols of the dried feces or ingestion of food contaminated with rat urine or fleas feces, including mites and ticks also. I have only shown the cycle for the mite. Similar cycles are present for similar mode of transmission is there for fleas and ticks and louse. Mite, it starts with mice, and then the intermediate hosts are the rats or mites, and then the mites from the infected rats bites the human that are the accidental hosts. No direct person-to-person transmission is present, and usually these mites, ticks, or louse are present in form of islands. In case of mite islands, these are the infestations of larval infestations of these mites in animal dens and bird dens, and usually present in endemic regions worldwide. The incubation period, I have just shown here the average incubation period, but it varies from disease to disease or subtypes of the rickettsial diseases, but on average it ranges from 2 to 14 days. Now I will discuss in detail first the scrub typhus. Scrub typhus is endemic in North Japan, Southeast Asia, the Western Pacific Islands, Eastern Australia, China, and several areas of South Central Russia, including India, also India and Sri Lanka. The agent of this disease is Rickettsia sutsugamushi. Reservoir is tuberculoid mite. The mode of transmission is through the bite of an infected larva, and the disease, as I've already mentioned, is not transmitted directly from person to person. Transmitted through the bite of an infected mite, and its incubation period ranges from 10 to 12 days on average. The clinical manifestations of this scrub typhus is characterized by fever and eschar. Eschar is a typical lesion on the body with black center and red margins and dry scar patch, usually present on the limbs. Typical scar is the scrub typhus marker. It also have regional lymphadenopathy and may have maculopapular rash and leukopenias. Organisms of scrub typhus is sensitive to chloramphenicol and tetracycline, which are the drug of choice in the treatment of rickettsial infections. Second is the tick typhus. Tick typhus, the causative agent is Rickettsia gonorrhoeae. The reservoir of infection is the ticks. And usually the life cycle, there are two distinct it is infected at all stages of its life. This is a distinctive feature of this reservoir tick, that it has trans ovarian and trans stadial passage. Trans ovarian means that the bacteria is transmitted from the female species to the larva, and transstadial passage means that that the tick is infective in all stages of life, including the nymph, the larva, the nymph, and the adult. And the rickettsia can be transmitted to dogs, rodents, and animals that maintain the disease cycle. Rocky Mounted Spotted Fever falls in this group of disease, and it's the mode of transmission of this disease is humans are the accidental hosts, and they acquire the infection by the bite of an infected tick. And contamination of skin with crushed tissues or feces of an infected tick may also cause infection. Within 3 to 7 days, the symptoms appear. This disease has close is closely it closely resembles the other febrile diseases, and sometimes it is misdiagnosed, and or we can say that it is sometimes missed. And it's very important to diagnose it at the right time, because if because it can be fatal. The most important clinical features that are involved is the high grade fever with petechial rashes on wrist, ankles, palms, soles, and forearms, with muscular and joint pains, abdominal pain, and diarrhea. And the skin manifestations usually begin 2 to 5 days after the onset of fever. Erythematous macules appear on wrists, ankles, and forehead, forearms. Now is the Q fever. Q fever is mainly in persons associated with sheep, goats, cattle, and other domestic animals. The agent is Coxiella burnetii. Animal hosts are cattle, sheep, goats, ticks, and wild animals. Modes of transmission. This is the only rickettsial infection in which the arthropod is not involved, and it has an aerosol transmission. Inhalation of an infected dust from soil previously contaminated by urine and feces of diseased animals. The organisms can also be transmitted through aerosols, as I've mentioned. And the respiratory route is regarded as the most important in this case. Food-borne diseases can also occur. Food can also be a source of transmission, contaminated food. Clinical picture is like influenza or other non-bacterial pneumonia rather than other typhus fevers. There is no rash or local lesion, and the infection can cause pneumonia, hepatitis, encephalitis, and it causes rarely endocarditis, but whenever endocarditis develops, then we label it as chronic Q fever. In chronic Q fever, there is a prolonged treatment with doxycycline and hydroxychloroquine for 18 months. Otherwise, tetracycline and chloramphenicol can also be used as a treatment for acute Q fevers. But in case of chronic fever, we only use doxycyclines and hydroxychloroquines for at least 18 months. These are the distinct rashes: the eschar, the Prowazaki epidemic, and the Rocky Mountain spotted fever rash. Now, a little bit about the typhus fever. There are two groups: endemic typhus and the epidemic typhus. The endemic typhus is is a disease. Rickettsia typhi, dull red, spreads in the middle part of the body with high-grade fever and have symptoms of abdominal pain, joint pain, and hacking dry cough, and nauseous. While in epidemic typhus, the vascular involvement is there, and it has a plain rash, high grade fever, muscle joints aches, and there is usually low blood pressures because of the vasculitis and vascular involvements. The endemic type of typhus is primarily maintained in rodent population, is transmitted via flea, and human is the accidental host, while the epidemic typhus is transmitted from human to human via louse. It is a louse-borne disease. And epidemic typhus is mostly prevalent in Africa, Asia, North and South America, while I have also written here murine typhus, which is due to rodents and is a flea-borne and tropical and subtropical areas. Brill-Zinsser's disease is an exasperation of an epidemic louse-borne typhus fever caused by Rickettsia provoziti. Rather than being eradicated, the microorganisms become latent and only to reappear after several years as a milder form of the disease. So this is an important point related to the epidemic typhus. Now the levels of prevention. Primary prevention includes health promotion and specific protection. Health promotion includes vector control. Vector control is the clearing the vegetations where rats and mice live. Application of insecticides such as lindane and chlordane to ground and vegetation. Control of fleas with residual insecticides, BHCs and malathion are effective. Rodent control is important in the affected areas, and other preventive measures include pasteurization or boiling of milk to inactivate the causative agent, providing sanitary cattle sheds, adequate disinfection and disposal of products. An inactivated Coxella vaccine has also been prepared to product, but still it is under trial, and several purified vaccines are under development. Personal prophylaxis in known tick infections in areas should be avoided. Daily inspection of the body for ticks is particularly important for those who are exposed to the risk of infection. Disinfection of dogs will minimize the tick population. Health education of people is the mode of health education is important, and the means of personal protection are equally important. No vaccine for humans is developed yet, and several purified vaccines are under development. In secondary prevention, early diagnosis and prompt treatment is important. For diagnosis, isolation of rickettsia is important. Serological tests like indirect fluorescent antibody test, complement fixation test, and wheel Felix test. The most commonly used and standardized test is the indirect fluorescent antibody test. The newer techniques involves ELISA and fluorescent antibody staining for the frozen sections of the rickettsial lesion except Q fever. And among these two techniques, the fluorescent antibody staining is more preferred than over ELISA. As I have already told, that tetracycline is the drug of choice of treatment for all rickettsial diseases. Other long-acting antibiotics like doxycycline and minocycline are now available that make a single-dose treatment possible. Both tetracyclines and fluoroquinolones limits their use because these antibiotics are contraindicated in pregnant women and young children. And doxycycline is the drug of choice for pregnant females and children, approved by CDC. Now the recent advances. First of all, I will comment on the vaccination because it is a neglected challenge, and the attempts of developing a vaccine, effective vaccine for humans, have started from since 1924. First technique that was used for the development of the vaccine was vaccination with an inactivated rickettsia as a whole cell antigen. Formalin inactivated bacteria was used, but no effective results have been shown in the humans. Second technique that is being under study is vaccination with live attenuated. The first trial started in 1936, and the use of these attenuated mutant knockout strains is promising method, but still there is no success in developing the vaccine. Immunization with antigen presenting cells and recombinant antigens is another technique, but still the technique fails to show effectiveness among humans. Vaccination with recombinant proteins of OMPA and OMPB. This is a promising technique, and This is the most important aspect by which we can, or most acceptable method by which we can develop a vaccine. But still, that the vaccine has not been developed, and trials are being done for to develop a potent vaccine for humans. In Pakistan, in recent years, several studies have been conducted, and in one study, through polymerase RT-PCR assays, um, Coxella bonnetti species have been identified in the soil or the agriculture areas of Punjab province. And these studies needed, further studies are needed to ascertain the bacteria's molecular epidemiology over a wide geographical area, types the isolates, and evaluate the potential risk to human population and particular farmers and veterinarians. In the second study shows that there are seasonal dynamics of ticks in different areas of Khyber Pakhtunkhwa. Although ticks prevalent in various agro systems of Pakistan associated with economic losses, information is still missing about the ticks diversity, host infest, seasonal dynamics, and molecular phylogeny in Pakistan. The seasonal patterns of several tick species showed high infestation during to July, August, September, in which high temperature and humidity persist. The collection of tick species were done and studied in the areas of Khyber Pakhtunkhwa, and further studies are needed to identify the functional role of these parasites in transmission to the human disease. Bovine ticks have also been identified in Pakistan, and ticks and tick-borne pathogens are the major constraints to the livestock production in Pakistan. And the present study investigates the tick-borne microorganism bovine ticks in Pakistan and employing a high throughput microfluid real-time PCR-based techniques. Now it's time for the MCQs. A patient complained of chills and fever following a louse bite 2 weeks before. He had rashes all over the body and was delirious at the time of presentation to the hospital, and subsequently went into coma. A provisional diagnosis of vasculitis due to rickettsial infection was made. Which one of the following you think is the causative agent? C is the right answer, because I have given two hints. Hanji ma'am, sorry. C is the Rickettsia provozaki is the right answer, because I have given two hints, that louse bite and the vasculitis, and it clearly refers towards the epidemic typhus. Second, which one of the following bacterial zoonotic diseases resembles the symptoms of influenza and pneumonia and transferred to humans through goats, sheep, and other cattle? Q fever. Q fever, because in Q fever, there is aerosol transmission, no arthropod is involved in its transmission, and the reservoirs of the disease are goats, sheep, and other cattle. So the answer is B, Q fever. Now the third MCQ is, a young boy presents complaining of joint pain, diarrhea, high-grade fever, and petechial rash on palms, wrist, and soles. While taking a detailed history, you find that he recently got a new dog as a pet. Yes, B is the right answer, because I already mentioned that the typical presentation of the petechial rash in case of Rocky Mountain spotted fever with the history of high-grade fever on wrist, palms, and soles is the classical feature of Rocky Mountain spotted fever. Which of the following rickettsial disease is not transmitted to humans by the bite of an arthropod? Yes, it's a repetition, but I wanted to emphasize on it because it is the only disease that has an aerosol transmission. A 32-year-old male presented with a history of fever with shivering, shaking, and chills, aching body muscles, and underlying cardiac disease, endocarditis. There is no history of rash or any lesion on the body. What is the drug regime used in the treatment of such patient? Alpha. Yes, alpha is the right answer. First, I will explain how we will reach the diagnosis. I have given two hints. I have given the underlying cardiac endocarditis, and the second most important hint is no history of rash or any lesion. It directly goes towards the fever, because I mentioned, if there are underlying cardiovascular diseases, in case of flu fever, then we label as chronic Q fever. And the best combination for the treatment in case of chronic Q fever is doxycycline with hydroxychloroquine up to 8 weeks. Other options are not right. 6. Which of the following is not the proper preventive method to control rickettsial infection? Use of insecticides to control the vectors and reservoirs, elimination of rats and mites, proper hygiene and use of sulfonamides for treating fever. Yes, because I am told that sulfonamides are the only antibiotics that enhance the growth of rickettsia. Dash fill the space, also called resistant typhus. It is a late relapse of epidemic typhus. Yes. The occurrence of symptoms like the previous infections and can be transmitted. Yes, the answer is C. It's a Brill-Zinsser disease. This is an exacerbation, late exacerbation of the disease that comes in phases, and the disease is milder as compared to the epidemic type because of the latency of the organism. What is the most widely used serological test for the diagnosis of rickettsial? Yes, as I mentioned, there are two techniques, ELISA and immunofluorescence technique, but we prefer immunofluorescence technique over ELISA when we are using skin biopsy. All of the following are the general features, signs, symptoms of typhus disease, except SPAR. On the negative side, respiratory lesions, lymphadenopathy, and the positive is Rickettsia australis. It is Sutsugoshami. I think this is the right pronunciation. So D is the wrong answer. Which of the following is not correct about the characteristic of Rocky Mountain spotted fever? It is caused by Rickettsia rickettsii. It is mostly found in eastern and southern regions of United States. Fever and skin rash develop within 6 hours of tick bites, and ticks are the primary. C is the right answer because I clearly explained that the rash appears 2 to 5 days after the onset of fever. So C is the wrong answer. This is the key that the references and things.